All right, well, let's jump in. We'd like to welcome you to today's webinar, Solving the Chronic Care Management Puzzle with Smart Patient Engagement. Our guest speaker today is Jordan Dolin. Jordan has been involved in healthcare innovation for years, and he's the founder of ME Solutions back in 2001, and it was one of the very first patient engagement platforms. So since then, Jordan has been involved in a number of initiatives and efforts and great new innovations, and will be sharing with us today, but also here as a resource for all of you that are guests in the audience. And would love to hear from you about any challenges, questions as you think of it. Jordan's been a great source for information, insights, not only for this but for other webinars. So without more further ado, I would like to introduce Jordan and hand over the mic to him. Welcome, Jordan.
Thank you. Happy to be here. I'm going to take it from the top and tell you a bunch of things you already know, but I'll try to keep it short. And that is, as we all know, the United States healthcare system is a complete mess. And not only do we spend more than twice as much as the next westernized nation, we lack in many areas with respect to quality. So although we spend more than double the next advanced economy, we still score well below average on life expectancy, well below average on uncontrolled asthma, well below average on unmanaged diabetes. And so we're not only spending more and getting less, we also do it very inefficiently. And what I mean there is that we spend almost 3 times as much as the next closest country on administrative costs, and that's Germany. So we actually spend more per person in this country on administrative costs than we do on providing long-term care. So it's a mess. And again, you all know that. I had to just throw that out there because it sort of sets the stage for everything to follow. So if you want to go to the next slide. So I covered this in my talking points, but the key takeaway from this is that in addition to all of our shortcomings, we also have the highest percentage of adults with 1 or more chronic conditions. And the only aspect where we're really truly a leader on the world stage is obesity. So it's a mess, and that's what we're here to talk about today, how we go about solving it. So if you jump to the next slide. So after you've heard the baseline of okay, the healthcare system is messed up, it's also lopsided. And that is, we've got a small percentage of the population who are consuming the vast majority of the resources. And really what that comes down to is the very nature of the US healthcare system. We have been, again, you've all heard this, we have what's called a sick care system, not a healthcare system. So we spend all the money treating people with chronic conditions rather than investing in preventing them. So we have the lowest utilization rates of wellness and preventative care. And so what we end up with is not fewer, it's a growing number, but a small percentage of the population consuming all of the resources. And the only way to fix this is by investing in preventative care, wellness, health, all of those things. But the problem is, as we spend more and more on the sickest people, it reduces the resources available to actually get us out of this situation. So it's a completely unsustainable situation. And you can go to the next slide. And as we know, it's completely gotten to a crisis point. And we can't keep ignoring it, and things are starting to change. And again, having spent now 20 years in the healthcare innovation space, I have to take a little bit of a dig at Epic, because for 15 plus years, any type of innovation that people start asking for, Epic will usually claim, oh, that's in our next release. And I can tell you the solutions that we need to fix this problem aren't going to come from Epic or any of the other EMR vendors. And if you flip to the next slide, And just to let you know a little bit more about my comments on Epic, they were the most vocal voice fighting the rules from HHS about forcing interoperability. But we'll circle back to that. So we now know that the only way to truly fix the U.S. healthcare system is by accomplishing the impossible. And rather than calling that, because that would frighten people, we said, you know what, we're just gonna call it value-based care. And really what that comes down to is that we need to reduce the cost of care and improve the health of populations and improve the overall experience of care while reducing costs. And it seems impossible, and in many regards, it is impossible, but only when you look at it through the lens of how the U.S. healthcare system is actually working. So if you go to the next slide. So we know that the current approach to fixing healthcare isn't working, and that is you've got this small segment of the population who's consuming the resources. So for some reason, people thought, well, it's a really good idea to just try to reduce those costs, to squeeze more and more efficiencies out of this area, and that just simply doesn't work. And that is really a race to the bottom. It won't fix it. So the only real viable solution in the long term is to reduce the number of people with chronic conditions. And obviously some people are going to get chronic conditions, but even amongst the people who have those issues, to reduce the percentage of them that suffer complications, who don't have them under control, so on and so forth. So the economic incentives are now shifting in that direction. All of the things going with, shared savings, fee for value, on and on and on and on. But at the end of the day, the underlying assumption of all these ways to manage population health are extremely optimistic, because they are all based on the idea that patients will become very active participants in the care process. And again, I'm a big believer in that patients can be involved. They want to be involved. But it's going to take a whole lot of behavior change. And the only way to make this happen is by really focusing on patient engagement, because without the patients playing an active role, none of this works. And if you want to flip to the next slide, and by the way, when I talk about patient engagement, a lot of the things that I just sort of take for granted is because I spent 20 plus years doing that. But what I will tell you, because I'm always trying to share the most up-to-date data, there was an Accenture survey done last year, and that 87% of patients want to be able to control and manage their own health data, and 78% of patients are very interested in mHealth tools. And again, we'll get to more of this later, but we'll go on for the moment. So again, we're going to use hypertension as an example. It's one of the big chronic conditions that consumes a lot of money in this country: asthma, diabetes, hypertension, COPD, all of those things. So interestingly, we know how to treat hypertension, and we've known how to treat it for a long time. And yet somehow the number of cases is growing. The average patient in this population is getting younger, and hypertension now affects 50% of adults, and yet only 25% of those, so it's 50% of US adults have hypertension, and only half of them have it under control. And there's medication that's readily available, and this simply shouldn't be happening, and it's killing 1,000 people a day. 1,000 people, not peoples, a day. So if we go to the next slide.
Frank, I'm sorry, Jordan, we had an interesting question or comment that it may be obvious, but we were talking about patient engagement, and Jenny in the audience mentioned, the people who would benefit the most from being engaged are often the least engaged. And I think you'll talk to that a little later on too.
Well, and I can tell you a little bit about that, and it is surprising, because in many respects, Yeah, that's true. Wait, you can go back a slide because this is our big punchline here. It's true that a lot of the people who should be engaged aren't engaged. And yet, when you look at the demographic and psychographic profiles of who can succeed with patient engagement, people are often surprised. They'll think, oh, underserved populations won't use ML tools and this and that. And that's actually completely untrue. I mean, it's, again, I've learned this through stories of friends in the industry, but I've also seen the data about it. And it is shocking. But again, yeah, a lot of people with a chronic condition that can kill them should care a little bit more about that. So, how can it be that we've known about hypertension for actually well over almost 180 years, something like that? And the reason these rates keep getting worse is because we're treating the wrong problem. This is not a clinical issue. It's a compliance issue. Doctors know how to treat hypertension, and they've known for years. The problem is patients simply don't listen, don't remember, or don't care. Another big punchline. Now you can go to the next slide. So, like I said, we have a long history of hypertension. It goes back. It was originally diagnosed and called Bright's disease by Richard Bright in 1836. The term hypertension came about in 1911, and soon thereafter, before 1920, people realized that sodium exacerbated hypertension. So it's been over 100 years that we've known how to control hypertension, at least the beginnings of it. In the 50s, we had diuretics, and beta blockers came out in the 60s. And the guy who developed those won a Nobel Prize. So for 50 years, we've had medicine that can effectively treat hypertension and diet and exercise guidelines. And doctors share this with patients, and it's just not working. And there's lots of excuses. Oh, I can't get to the pharmacy. I can't get to my doctor. I can't afford the medication. Oh, I feel good, so I don't need to treat this, or I'm overwhelmed because there's, too many other things going on in my life and other conditions. Okay, so now we can jump to the next one. So there's tons and tons of data showing that these conditions can be controlled. Unfortunately, primary care physicians don't have the bandwidth to provide the care that they want. And so what you have is and this is just walking through an example, and if we've got clinicians on the phone, their numbers may be a little bit different, but on average, a primary care physician has 2,000 patients that they treat. And this is not a pediatrician, but an adult doctor, and half of them are hypertensive. So what you have is a very large number of people, and 75% of those patients require additional support. So you're talking 1,500 patients, and if you scale that up to a group of providers, you've got 25% of your 2,000 of 500, 75% of them needing additional support. A group of 4 primary care docs has 3,000 patients that need additional help to keep their hypertension under control. So if you just spent 1 minute per patient per week, and obviously that's not right, but picture a monthly phone call, you're talking 2,600 person hours to just manage that one condition. That's 1.5 FTEs for a single chronic condition. So you're looking at a nurse or a trained person at $100,000 a year salary for a 4-doc practice. It's simply not viable. It's not affordable. So we're in this spot where we can't afford to do the things that we need to do to get us out of the rut that we're in. So now if you go to the next slide. So technology has been proven over and over to be able to successfully extend limited resources of clinicians. And I'm just looking at Well, there's study after study after study, depending on who you ask about how effective these tools are. So even if you don't believe that patient engagement platform would change behaviors, although I know that they do, you can use them to provide appointment reminders, medication adherence prompts. You can give them background information about hypertension. You can answer their most common questions. From the clinician side, they can have access to patient-generated data. I have hypertension. I've got it controlled. I exercise. I do what my doctor tells me to, but she still wants to know, how am I doing? Imagine if she could have access to my data from my Apple Watch or from my Orange Theory armband or whatever they wanted. You can also use these tools to create customized care plans and connect patients with other valuable resources that they may need. And you can also motivate them in different ways. They can compete against themselves, against each other. And the one piece of, well, before I get to this slide, the one piece of information that I wanted to share was a study that came out late last year that I thought was fantastic. And it was a University of Michigan study. And so we all know people with hypertension. Hopefully, if you listen to what I was saying, it's extremely prevalent. Half of adults have it. People don't check their blood pressure, blah, blah, blah. The University of Michigan did a study with Apple Computer, and they gave people an Apple Watch. And they had 6,500 participants, 55% women, 45% men. And the population was made up, really reflected the American population in terms of geography, ethnicity, on and on and on. So across a 90-day study, 6,400 participants had 1.17 million blood pressure readings over 90 days, which is insane. So if you think about that, these participants are reporting their blood pressure multiple times every day automatically. Now compare that to how many people do you think test their blood pressure 3 times a day and upload it into MyChart? It's just doesn't happen. Okay, now we can go to the next slide. Okay, so, and again, I'm now leaning upon my years in the patient engagement space of talking to hospital system executives. And oftentimes I would hear things like, okay, well, I agree with you. Engagement works, it can work. I've seen the data, but we already have a patient portal to engage our patients. And, saying something doesn't mean that it's true. And, to put this in perspective, 60% of all patients report having been offered access to a portal. 20% ignored entirely, 20% sign in once or twice, and 20% are considered active users. So that's 20% of 60%. So you've got 15% of the 60% of patients who've been offered a portal account who are active users. And by active users, that means they log in roughly once per quarter. And the reason they log in is usually to make an appointment to refill their medication. Now, compare that with a popular app, the Facebook app. 214 million active users in the US. That's more than 2/3 of the population, and 85% of people access it every single day. And I also have a nice little stat here, and that is over the last 12 months, this was a 2019 into 2020 study, 0.07 of patient portal users, and again, that's a tiny fraction, downloaded their health record to a phone or mobile device. So the utilization for portals just isn't there. We'll touch upon this a bit more. And now you can go to the next slide. So again, everybody agrees that the future of healthcare and bending the cost curve really comes down to engaging patients. The problem is that the EMR providers keep claiming, well, that's what a portal is for, and they're great, and yada, yada. But at the end of the day, people aren't using them. And on top of that, you've got a platform here that was created to support clinicians and hospitals. It was never designed to be patient facing. And patients view portals as a convenience to schedule things, to basic communications, but they don't look at them as a way to be motivated, engaged, to change their behavior. And it simply won't happen. And I keep stressing this because this is really what it's coming down to. The future of healthcare to bend the cost curve and improve the health in people in the US really requires patients taking an active role, and that's on a consumer-centric platform. And the longer the EMR vendors keep fighting that, the worse off we're going to be. So you look at the abysmal trends in portal usage and then compare those to the trends in mHealth. We can go to the next slide. Sorry, Jen, I'm not doing a good job prompting you.
It's okay. There's a little delay, Jordan, so thanks for your patience.
So I thought I had an mHealth slide here. Well, maybe that's coming in next. So again, I've spent 2 decades in the world of patient engagement, and it's a complex science. It's not that simple. And for years, people would confuse patient education with patient engagement, and they really aren't the same thing. Patient education is passive. It's meant to inform you if you want to learn more. Patient engagement is active. It empowers and engages the individual. And if any of you are familiar with the term PAM, it's patient activation measures. You can actually quantify a person's, how engaged they are in their care and likelihood of change and all of that. So again, patient education has been around for decades. Patient education is a new field, and it is purpose-built to drive certain behaviors and change outcomes. And, to be successful at this, and my company, ME Solutions, was one of the pioneers in the field. And we probably spent over a decade and $30 million building out a very comprehensive library. And to be able to engage somebody, you have to understand health literacy, how different populations learn using different modalities. Because some people are visual learners, some people are auditory learners, some people need to read and hear. You also have to understand the frequency of messaging. These are things that come from the world of marketing and advertising, of what it takes for the human brain to actually absorb a message. Being able to deliver content and information during a teachable moment, and also understanding the cultural sensitivities and socioeconomic factors of the audience that you're speaking to. So it's very complicated, and it's extremely effective if you get it right. But right now everyone's claiming, I do engagement. And my favorite was the in-room TV vendors used to, and maybe they still do, describe themselves as a comprehensive patient engagement platform, even though less than 1% currently of healthcare encounters take place in a hospital bed. I mean, it's ridiculous. Okay, I think we can go to the next slide. Now, Jen, I'm just plowing through. If questions are popping up, feel free to interrupt me, or I can just keep going.
Will do. Yeah. As a reminder to the audience, feel free to drop any questions in the chat, and I will jump in with them and give them to Jordan.
So, and again, I apologize if I'm going quickly here. I hate to drone on too long, so I'm trying to keep it moving at a decent clip. So if you look at where healthcare is going, and beyond the obvious, we have to reduce costs and improve quality. Okay, great. Yeah, we all know that. So if you look at the trends, wellness and prevention, experience of care, patient-centered care, patient preference-sensitive communication, patient-reported outcomes, treating healthcare as a service business, blah, blah, blah. If you look at all of those things and think about what's going to really support these, it's a consumer-centric platform. I'm a tech-oriented person who cares about their health, and I spent 20 years in healthcare technology. I don't have the Epic MyChart app on my phone, but I have like 5 other health apps that I use all the time. So if you think about where healthcare is headed, are people like me going to give up all of their, chosen apps, devices, all of those things, and suddenly hand it off to an EMR vendor? I mean, it's preposterous to think that that's the case. And yet, we still have people promoting that. And the head of Epic, in my opinion, is the worst offender. They're the ones who are blocking innovation and keeping innovators from being able to connect effectively with that EMR platform, unless they're willing to give a third of their revenues up to, Epic. So anyway, okay, we can jump to the next slide. So when you think about where healthcare is headed, which platform supports the future? Patient portals, where you've got less than 25% of people have ever even registered for an account, much less use it. Something they access on a very infrequent basis. It's not viewed as an engagement platform, not designed for patients, can't share and collect data unless you input it, and it is certainly not consumer oriented. Now let's compare that with mHealth devices and apps. Adoption rate is very high. 64% of all US adults use a health app on a regular basis. And this includes very old people who may not even own a phone. So when you look at that number, you realize that this is growing and growing and growing. People access their phones and their iPads and their other devices all the time. And people look at mHealth apps and devices as a platform to support their health. People don't buy, exercise band or an Apple Watch or download diet apps because they don't care. They download these things because they want to improve their health. Obviously, all of these things were designed from the ground up to have an optimal user interface, user experience. All of these things have the ability to share data with their provider, and obviously they're consumer oriented. And I had a stat here, and that is 74% of patients who are using apps and wearables claim that it can help them manage their chronic condition, and 90% of patients who have an mHealth app or device are willing to share their results with their clinician. And 90% of clinicians are already using a smartphone. So the pieces are all there. And it's just ridiculous that we're still held up because we've got some people actively blocking the future. Okay, we can. Oh, and I missed the points down at the bottom there. 93% of clinicians believe that these things can help improve outcomes. And hospitals, 3/4 of hospitals believe it's more efficient to use these apps than to use their EMR. Sorry, I'm a little rusty. So, to me, this is a great way to summarize the things we were covering. And that is, the future is consumer-centric. And you don't have to believe me. It's just the writing's on the wall. Patients want to be involved. They want to be engaged. But they want to be engaged on their terms and on the devices they already own. So think about it this way. Does somebody want to drive to Walgreens, buy a Bluetooth cuff, try to get it synchronized to their computer, make sure their computer's on when they're putting it on, try to get your armband reimbursed by Blue Cross, then start checking your blood pressure 3 times a day, then log into MyChart or Cerner's version or Allscripts version and enter your data, and then do those the last two things for the rest of your life? Or you could just buy the new Apple Watch, click one button, and share the information with your doctor. So, that to me is the reality. And then I think the last slide is, what hypertension care could be. Well, it could be on your phone, and you could have everything that you need to support your health and wellness and improve your chronic condition on their phone. With an Apple Watch or any other device, you can automatically collect and record your blood pressure. You can get whatever education you need, risks of non-compliant. You could get reminders and prompts for your medication, your upcoming appointments, when it's time to refill your meds, all of those things. You can track your exercise, get encouragement, count your calories. I mean, it clicks with your lifestyle. And I know that somebody had asked a question, somebody who worked at Capsule, I don't know if they're on the phone, if med adherence is part of this. And yeah, I'll give a shout out to Capsule because my son now works there, my oldest son. I had never heard of them, but yeah, their medication fill rates are something like twice the national average, and medication adherence is a huge issue with chronic condition management, especially for asthma, diabetes, hypertension, on and on. So again, this is where the future is headed. You're going to control your own health on your device and on your own terms. So with that, I don't think I have any more slides. I had all sorts of other data and things I wanted to, oh, well, this is my closing. Healthcare has entered the age of accountability. Outcomes are really the only thing that matter. There's a lot of people sharing a lot of misinformation when it comes to what is or isn't patient engagement. And at the end of the day, outcomes matter, and everything should be evidence-based. And, the way your doctor treats you, I mean, your clinical pathway is evidence-based. And I think that technology platforms should be held to the same standard. And, if you're not achieving outcomes and you're not truly engaging patients, you should be held accountable for claiming that you are, because you're just delaying the inevitable and making your patients sicker. So with that, I will turn it over for questions, wrap-ups, whoever has anything they want to address.
Do have one, Jordan, that we received prior to the webinar, and one of them was, will moving to a more consumer-centric approach necessitate hiring more healthcare workers at a time when we're already struggling with staff shortages?
Well, yes and no. Should your payroll in a health system go up? No, it should go down. So the truth is, right now, people see their clinician very infrequently for a very serious issue. You don't see your doctor for a year and then you're hospitalized with diabetic complications. So what you should be doing is having more frequent wellness and health visits and less time in the hospital, less time with specialists. So you don't need to hire more people, you need to hire different people. And if you think in Cook County, there's a lot of people who are overweight. I'm just using Cook County as an example because I live in Chicago. If you look at the number of people who are overweight and have hip and knee problems and end up having to get a hip or knee replacement, well, your primary care doctor is responsible to help you, encourage you to go on a diet and exercise and so on and so forth. So the person who's supposed to help you stay healthy on average makes around $150,000 to $170,000 a year. The orthopedic surgeon who works far fewer hours makes $2 million a year at the better, larger health systems. So the problem is that the wrong people are being compensated the wrong way to drive the behaviors that we need to bend the cost curve.
That's good. Frank, do you have any thoughts there too? I know you're pretty close to this as well.
Yeah, I'm pretty close to it. I think Jordan's spot on a few things, and I think I would sort of add this notion, which is, look, the intent is not for this to add additional headcount in a really, really tough, pandemic type basis. The notion is, how do you engage with your current patient in a more relevant way that is consumer centric? So we like to say skate to where the puck's going to be, not necessarily where it is. And you want to engage with that patient in such a way what they're used to, right? They have busy lives and busy schedules and things like that. But you want to push this out to the edge so that they're using their mobile basis. And what we've seen from our customers is they are able to do that with the current staff that they have at a much higher level, which is ultimately the whole reason that they take the oath in that way, is they want to engage with the consumer or with the patient in a higher level and deliver a higher level of quality care across that continuum. And that's exactly what a patient engagement application that is mobile first and customer centric is supposed to do. And we've seen that time and time again from our customer base.
And to echo that, going back to what I opened with, we spend more than twice as much as the other advanced economies on Earth, and we score below 50% on most quality measures. So we're spending enough money and we have more than enough people. The resources need to be reallocated.
That's it. And Jordan, I think you're spot on. I think, look, it's a tough time for anybody in that practitioner space, right? To really be able to do what they're trying to do. How do you engage with that patient in a much more streamlined way? Will ultimately deliver both things to that. And as we all know, we're on our phones a lot more than probably anybody would like us to admit. But that's the best way to be able to do it.
And for the first time ever, patients and clinicians are actually incented for the same outcome. Clinicians will make more money if you are healthier. And if you are healthier, you're much better off. It's like, it's pretty simple. You know, it's funny. The people who get rewarded the most in the healthcare systems are the one who treat the sickest patients. So like, it's good for you to do hip replacement because you're obese if you're an orthopedic surgeon. But
That's right.
The burden it places on the patient and the rest of the health system is ridiculous.
Well, it's two parts, right? I mean, of course, the clinician's going to want to provide a higher quality of care, but we all know that the patients don't listen, right, to what they provide, and that's because it's a non-digitized sort of format of the way that they're engaging, which is via paper or whatever the mechanisms happen to be of going to a portal or anything like that, instead of what they're used to. So it's as if we say they're speaking past one another, right? If the patient was just more adherent, of course, that would deliver a higher quality of care. But again, for all the reasons that we mentioned before, they're just not. So why not push that to something they engage with every single day, which is that consumer-centric app focus?
To jump off of that, Frank, we had another question I think that leads really nicely into that. When you mentioned, getting paper forms, I've done it with my dad. We've walked home from 2 visits in one visit with 42 pages of paper. And I care about my dad's wellness, and we don't even get to read through all of that. So I think I know some of the answer to this, but the question from one of the earlier submissions was, how exactly will the patient engagement, or will the engagement strategies and tech you propose differ from our current best practice patient engagement process?
Yeah, I think it's a great question. I think that you already have the content in most cases, right? 42 pages of care. There is probably a lot of really good information in there. But to your point, you're not really going to read through it or have the time or the patience to be able to do it because you want to make sure your father's in a safe place. The data, the information is there. The content is there. It's just how it's disseminated. And if you're opening up a way to give it in a more streamlined, automated way that the consumer, i.e. the patient, is used to absorbing that information via their smartphone, via their technology, it's much more likely to be engaged. Can you push that into a much more task-based, way, right? Where there are certain checkbox. In addition to what we're doing on the platform is we're also making gamification available, right? How do you engage them in a much more automated way, in a much more automagical way than what they're used to? And if you can gamify that information along the way, you're going to get higher results, you're going to get higher adherence, you're going to get higher engagement, and a much happier patient. And therefore that clinician's also going to be happier because that patient's going to be in a better quality of life.
And to echo that, you said, are we going to have to change our current engagement approach? Well, that's sort of an open-ended question because I don't know who asked it and what their approach is. There are lots and lots of places who are getting it right and have done it for a while, and it's not always who you would think. I remember one of the earliest health systems that I read about that was really effectively doing population health, and this is more than a decade ago, was a system out of Green Bay, Wisconsin called Bellin Health. And I think there may be like a 75-bed hospital in Green Bay, which is, if you're from Chicago, that's the middle of nowhere. And yet the CEO at the time, I can't recall his name, was a visionary and understood what it takes and had these people in, rural geographies in northern Wisconsin effectively managing their chronic conditions. So it's the right tools and deployed properly. So this stuff can work. And, you just have to do the evidence-based research to find out what's going to move the needle with your patients.
Great point. One other, to pivot the topic a little bit, an additional question we received was around just structure of how we pay for healthcare. So it seems to require a change in how we pay for healthcare. Do we need to change our fee-for-service structure before we change our patient engagement strategy?
Yes. The financial incentives aren't aligned, and it's never going to work. Fee for service, by its very definition, is the more stuff you do, the more money you make. And that doesn't make sense. And the analogy I always use is, could you imagine if your washing machine was leaking all over your house and wasn't working? And you paid somebody, they came in and they left after 8 hours and they gave you a bill for $1,000 and your washing machine still wasn't working. And they're like, I went through the manual, I did everything. Here you go. You didn't fix it though. And literally that's what we pay for in healthcare. And I'll give you a very fun thought experiment for the people who are still on the phone. Go online and find out, look at where our healthcare's dollars go. Just find the picture, like a pie chart. This much goes to drug companies. This much goes to insurance companies. This much goes to primary care doctors, this to surgeons. Look, and then just set that aside. And then draw your own pie chart saying, okay, here's the constituents. Who deserves how much credit? How much credit should a primary care doc get? What percent should they get? What percent should the drug companies get? And you'll realize that the pie that you draw is very different. In Illinois here, Blue Cross is the leading payer. They're a not-for-profit who makes a couple of $1 billion a year in not-for-profit. My family pays $30,000 in premiums before we have coverage. And I work out every day and I don't smoke. Like, what is up with that? That's what's got to change. So yeah, the financial incentives have to change.
Frank, thoughts from you there?
No, I mean, like the yes, it has to change, right? Because everybody really wants the same thing, which is a higher quality of care, no matter where it's coming from. And I think you just got to make sure you're engaging with them in the proper manner. But he's 1,000% right.
Absolutely, Jordan. I think we're winding down on the questions that we had. Were there any other pieces that you had, closing thoughts on, either you or Frank? Feel free to share any of those things we might not have gotten to cover.
I have one last thing. I had a quote that I wanted to end on. And again, I know I keep harping on the EMRs, but it's frustrating to me because these tools are out there. I had launched a company that helped pioneer these things. And it frustrates me that these are being kept from people. And this is a quote I found recently from the CEO of Fairview Health. I will submit that one of the biggest impediments to innovation in healthcare is Epic, because the way that Epic thinks about their intellectual property and the IP of others that develop that platform. And the Mayo Clinic did a study across all EMRs, and it said the usability of EMR systems received an overall grade of F by physician users. Their approval rating was 9%. And physicians have to use these things because it's a requirement of their job. So this is how clinicians feel about them. And all of us as consumers are supposed to willingly jump onto that platform. I mean, it's all about the consumer. And as Frank has said over and over, people want to be engaged on this, the thing that's never far from their hand.
That's right. That's right.
Exactly. Yeah, that empowerment angle is such a differentiator in and of itself. If you have the tools in hand, we're so used to it being readily available. We'll engage with the right tools.
I want when I want it. That's just that's healthcare is a business and it's a service business. And I would encourage everyone to look up the golden rules of the service industry and it's hysterical. Like it is the polar opposite of healthcare. Don't make your customers wait. Always say please and thank you. Always accept responsibility. It's like, yeah, that's going to happen.
Totally.
Cardinal rules. Well, Jordan, thank you so much for joining us. Frank, thanks for chiming in with your insights as well. I know you'll be following up, I think, via email. If folks have other questions, you'll be reaching out to them.
Yeah, we'll get that out, Jen. And so there'll be another outreach to the team or from the team. There'll be a Calendly link, and my email will be in there. And we'd love to be able to service the needs and answer any questions that might come available. But we really appreciate everybody's time and participation here.
Great. Thank you again, everyone, for attending, watching, tuning in either live or on the recording. And Jordan, thank you again for being our guest speaker today. Hope everyone has a great rest of your day.
Thanks, everybody.
Thanks everyone. Thank you. Bye-bye.